This program is brought to you by Emory University.
Good morning. It's my pleasure this morning to introduce Larry Allen, who's coming to talk with us. Larry's coming from Denver, from the University of Colorado. Larry has worked in many different areas related to heart failure, but is going to talk to us specifically today about some of his really interesting work looking at the decision-making process, particularly for VAD patients. To give you a little bit of background, Larry did his undergraduate work at Colorado, did med school at Harvard, residency at MGH, went to Duke for a cardiology fellowship in heart failure, and then has been on faculty for 8 years at Colorado, 8-ish years, and runs their heart failure program. Larry really has been remarkably active within the American Heart Association, and has really done what I think is really groundbreaking work looking at approaches to decision making. In particular, has a PCORI-funded contract to look at creating a decision structure and decision aid in the context of thinking about VAD therapy, which obviously is a complex and really interesting decision that many of us think about regularly. So I'll let Larry take over, but it's nice to have him here.
Great. Well, I want to thank Neil for having me and reaching out, as well as just everybody for being here early on a Monday morning. It's also good to see some old friends, and I look forward to the day spending time with you and learning more about your program here. So today I'd like to talk about, as was mentioned, this decision process in advanced heart failure, and I think that it's an area that's really fertile for understanding medical decision-making among patients and caregivers for a number of reasons, and that makes it an exciting place to do some work. These are some disclosures. So like any good story, I think it's nice to tell it in 5 acts. And so I'll start out talking about decision-making generally for advanced heart failure, then specifically highlight destination therapy, LVAD, which I think is unique from BTT, LVAD, and some other decisions. Talk about gaps I think that exist in decision-making, and then talk about development and then implementation of patient-centered decision aids. So Act 1, this is actually a fortune cookie my daughter got in August. She opened it up and it says, "Nothing is more difficult and therefore more precious than to be able to decide." And I thought that was a good fortune to come across. So we're keeping it in the family. So this slide I think is actually important because when I go around and kind of chat with people at my own institution or others about what shared decision making is, I get a lot of pushback, and people say, well, you just want patients to be able to make their own decisions, and people aren't really capable of necessarily doing that. It's not always right. And I think if you take a step back and really think about what it is that we do when we counsel patients and practice the art of medicine, there are a variety of things. And the most common, I think, is that we often recommend therapies where the benefit is greater than the risks, and so behavioral counseling is used when that scientific evidence for benefit strongly outweighs harm, like smoking cessation or beta blocker for heart failure with reduced ejection fraction. And decision support is then designed to describe, justify, and recommend. Increasingly, though, I think for difficult decisions in medicine, shared decision is most easily applied, where those decisions are preference sensitive, where both clinicians and patients agree that equipoise exists and decision support helps patients think through, forecast, and deliberate their options. So, I think the more complicated, the more trade-offs involved in decisions, the more I think we really have to revert to what it is that patients' values, goals, and preferences really help decide what the right decision is, because we may not particularly know what that is. I think also using kind of a shared decision-making process, even for areas where we'd normally think about behavioral counseling, is important, because I think the concept of engaging patients in their care is really important. At the end of the day, patients have the choice of whether they want to smoke or not. And so we can say, you need to comply, you need to stop smoking, And that hasn't been particularly effective. So even in areas where we have a strong recommendation for patients, to really say this is shared, because at the end of the day, whether somebody picks up a cigarette or not is their decision, to really engage them in that and activate them, even in those kinds of situations, shared decision-making, I think, has value. So it's really a spectrum. So the way that I lay this out for people sometimes is, if somebody comes in the emergency department with a ruptured appendix, we say, well, as it turns out, the CT scan shows that you have a ruptured appendix. That's why your stomach is killing you and your blood pressure is dropping. And we think you should go to the operating room right now. And if somebody said, well, I don't want to go, I think we'd probably call a psychiatry consult and maybe kind of go through that process with them. Whereas things like bariatric surgery are extremely complicated and have lots of risks and benefits trade-offs. And really, there are other options that people can pursue. And at the end of the day, that's a great example of how surgery should really be patient-centered. So if you think, well, this is all nice and well and good, but who really cares? Well, what I will say is that the payers are starting to care a lot more in addition to the patients. So CMS recently came out with their national coverage decision for left atrial appendage closure. And this is only one of two coverage decisions so far, the other being CT scanning for lung cancer screening, where they say that you have to do shared decision making in order to get paid. So the coverage decision reads, a formal shared decision making interaction between the patient and provider using an evidence-based decision tool on anticoagulation in patients with non-valvular AFib must occur prior to left atrial appendage closure, must be documented in the medical records, and must include a discussion of benefits and harms, must document an appropriate rationale to seek non-pharmacologic alternative to anticoagulants, taking into account the safety and effectiveness of the device compared to anticoagulants, and have, after being informed of the reported risks of left atrial appendage closure and reasonable alternative management strategies, given informed consent. So Medicare is now saying in order to pay for Watchman device placement, you don't just have to get informed consent from the patient. You actually have to go through what they're calling a shared decision-making interaction with a tool and then document that in the record. And they're actually asking that be done with not only the person placing the device, but somebody else. So this is coming, whether you like it or not, or whether you agree with what comes up in the following slides. So when I was trying to decide, when I was a fellow about a decade ago and trying to decide what I wanted to do with my career, I was really interested in kind of end-of-life issues for obvious reasons. I think, patients are very vulnerable. There's a lot of challenge around that. It's where a lot of expenses in medicine occur. But I think the other reason I really enjoy it is that that's where some of the most difficult, doctoring and caregiving occurs. Patients are in the ICU. The options may not be great. And trying to go through how patients deal with that very challenging time period in their life is, to me, very exciting. It's one of the reasons that I think many of us do procedures in the cath lab when people are sick, or work in the ICU, or take care of patients with left ventricular assist devices. And so actually John Spurtis, who was the QCOR AHA council member at the time, said, well, QCOR needs to sponsor, some statements. And he said, I think it'd be really great if you wrote something on decision-making in advanced heart failure. So so this is kind of around 2010, and so we put together a panel of people and ended up writing this scientific statement. And I think it's one of the more fun and actually more innovative things that I've ever participated in, because it was truly kind of a multidisciplinary group of people who got together and kind of tried to formulate what are the reasons why this is such a difficult time period in patients' lives, and why is the care complicated, and how do we approach that in a better way. And I learned a lot from this, and I think it really set me on the path of thinking about how do you help people make these decisions. So the other reason I was interested in this is that when you are thinking about advanced heart failure care, the options are complex and challenging. This is actually a slide I put together when I was working with Dave Markham at Duke all the way back in 2005, which is, if you move towards transplantation or mechanical assist devices, you're assuming big risk going to surgery, and the costs are tremendous. But if you're really truly failing your medical therapies, inotropic infusions have pretty poor data behind them and obviously are kind of palliative unless you're going to bridge a transplant. And a lot of people just really aren't ready for hospice care. So, these are the options we're giving people, and they're saying, I don't really want any of those options. So when you think about left ventricular assist device therapy, I think, like any therapy, it depends on the context in which it's being applied. So if we have a 32-year-old female with peripartum cardiomyopathy who has gotten progressively hypotensive after her diagnosis, is unable to tolerate any ACE inhibitors or beta blockers, has a narrow QRS, and you're kind of wringing your hands saying this is not going very well, and then she ends up in multi-organ failure in the ICU, we make a pretty strong recommendation that that's somebody who would typically benefit from left ventricular assist device or other MCS. And again, if she said, no, I don't want to do that, that would be a challenging situation. Now, we've had a patient very much like this who ultimately decided not to get therapy, but that's very different than the more typical destination therapy patient that we're confronting. So, we have a handful of patients now who've been over 80, but we see a lot of people in their 70s with multimorbidity. The reason that they aren't eligible for transplantation is not just age, it's renal dysfunction, longstanding diabetes, other things. And, they may be kind of intermax 4, pulmonary hypertension is going up, they're short of breath, really having trouble managing them, haven't quite gotten on inotropes yet. So what do you do with that patient? And that's a very different discussion, but I think one that we are increasingly facing. And based on the most recent Momentum HeartMate 3 data, I don't think that we're going to have such a huge change in LVAD therapy that this is going to be any easier decision in the next 5 or 6 years. So the national coverage decision actually for ventricular assist devices for programs that do this says that we must offer optimal patient-centered care, and we have to do this with teams. And those teams have to include not only a surgeon and a cardiologist who knows how to do this, but a VAD program coordinator, a social worker, and a palliative care specialist. So again, Medicare and other payers are saying that this is a really difficult decision, and you need to have a multidisciplinary team who knows how to think about shared decision-making and going through these processes. So I want to highlight how difficult I think trying to recommend a left ventricular assist device to a patient is. And I think some of it has to do with the trajectory in heart failure. So, if you have a patient who has lung cancer or pancreatic cancer and it's metastatic, there may be a lot of therapies that are available for those patients. But once the disease is pretty advanced and moving along and has failed kind of standard therapy, those patients have a relatively predictable clinical course. Now, it's not perfect even in cancer, but I think it's much harder in CHF or COPD or other kinds of undulating progressive diseases. I mean, I can't tell you how many patients I've had where I've sent them to hospice and then, they're back in clinic a year later telling me, remember when you sent me to hospice? And, that doesn't mean I'm not doing my job. I think it means I'm doing my job because it's just so difficult to predict how people are going to do. And, if you look, a lot of people keep trying to make risk models to say, okay, well, let's make a risk model so we know exactly who is going to need an LVAD or die otherwise and who we can continue to do medical therapy in. And so this is a systematic review of heart failure risk models. They actually had 114 different models, and the C indices for predicting whether patients were going to be alive or dead going forward was really not much better than 0.75. Occasionally you'll see something out there that's 0.8, but I think it just illustrates that if I take a patient who eventually dies and a patient who eventually lives, that 20 or 30% of the time the score is wrong. It's worse for the patient who lives comparatively, and that's, I think, pretty impressive. The other problem, I think, is that we rely a lot on risk models as if they help us make individual decisions. And I think the problem is that risk models are actually pretty effective for population management. And that may be great if you're, the head of CMS or Health and Human Services or a CEO at Kaiser, but it's not particularly helpful when you're sitting down in the clinic with a patient or in the ICU with a patient and you're trying to make a recommendation about a specific therapy like an LVAD. So this is some work that I was doing that is actually, everybody keeps telling me is really obvious, and I don't think it's very obvious. So we worked actually with 3 different Kaisers around the country. We collected all the data from their electronic health record, and we identified essentially 11,000 patients with heart failure. And then we took the Seattle heart failure model and calculated the risk model score for these patients. And essentially, you can use the Seattle heart failure model to give you a probability of death at 1 year. So you could have a 0% probability of death, or on the right here, 100% probability of death. And each one of these black dots is a score for an individual patient. And these are all the patients that live. So not surprisingly, most people that live have a pretty low risk of death. And there's a couple of people who the score says, yeah, they're really, really high risk, they may die. But I think what's impressive is that we applied this to the population. The C index is 0.68. And this is what it looks like for the people who died. So now the score is shifted a little bit to the right on average. But, you know, what a C index of 0.68 means is if I randomly take one of these and I randomly take one of these, you know, the person on top is going to have a score further to the right than the person on the bottom. But this doesn't tell me anything about whether I should take an individual dot and tell that person to get an LVAD. I just think it's ridiculous, and no matter how much time we spend getting more variables out of the electronic medical record and applying, you know, people's social aspects and other things, I really don't think that risk models are going to tell us all the time when somebody should either go to hospice or get a VAD or do something else. So this, to me, has been somewhat helpful, somebody who's spent a lot of time with risk models, to show that when you apply them to individual decisions, it's much more challenging. The other thing is that, you know, when you're trying to make a decision about whether you should do therapy A or therapy B, and you're trying to weigh all the different risks and benefits that are involved, that it's, you know, we focus on survival because you can count bodies and it's really easy statistically, but there's lots of factors that go into this, and it's really hard to build risk models that include survival and quality of life measures, and then costs and burdens and other things. Those are all things we can talk about, but I don't think at the end of the day that we're going to have a great algorithm that just you plug it in and it tells somebody what their decision is. So this is good for us because at the end of the day, it means that the art of medicine, you know, what we do as physicians really does matter and will not be replaced by some computer algorithm. But it also shows how difficult it is. So let me move on to Act 2. I want to talk more specifically about why LVADs are, I think, such a complex trade-off for patients. So the first is that there's really, I think, going to be increasing use of these devices. You know, if you'd asked me 5 years ago, I would have thought that in 5 years from now, you know, say 2020 or 2021, that we would be using these a lot. I actually think that the technology has plateaued a little bit, and so we're not really putting these in, you know, NYHA 3B patients. It really is reserved for people who are dying. But at the same time, certainly the technology is getting better over time, and we are getting more experienced at using these devices. Let me show you about how I kind of try and present the trade-offs to patients. So, you know, to some extent, LVADs are tremendous therapy. So if you are kind of Intermax 3 on inotropes, and you just go forward with that therapy, your survival at 1 year is about 20%, which you can see on the bottom here is kind of, you know, the classic rematch data for medically managed patients with severe heart failure. And if we use continuous flow modern LVADs, that survival at 1 year moves up to about 80%. So what I think is really impressive is that the number needed to treat to save one life at 1 year is 2. It's really like less than 2, which is staggering. So I don't mean to get up here and say that LVADs aren't miraculous therapies in any way, because they are miraculous. I mean, that's very impressive. The problem is that they come with a lot of burdens, and the death rate is still 20% at a year, which is not trivial. The death rate at 5 years is about 50%, as you know, and there's lots of complications along the way. So the majority of people, 55%, are rehospitalized after they get discharged, which is quite impressive. We all know about the problems of bleeding and stroke and device infections. Maybe the malfunction due to clotting will be less with the newer generation device, but ongoing heart failure has not disappeared. And I find that that's actually one of the things that patients are most frustrated about, that they have gone through this entire therapy and surgery to get rid of their heart failure, and then 20% of them continue to have RV dysfunction and heart failure, and that's quite disappointing for people as well, even if they do survive. So this is an amazing therapy in many aspects, but certainly not a perfect therapy. I also think for those of you who do this, one of the recent studies that came out was the Roadmap study, which was a non-randomized study, but they essentially took about 200 patients that they followed, and about half of them chose to get an LVAD early, before they really decompensated and were on inotropes, and half of them chose to wait. So again, that was a non-randomized decision. But what they found is that the survival among those two was not 80 versus 20%, it was 80 versus 80%. So if you aren't in the ICU on inotropes and can't get out, if you're at home and you feel pretty bad, but are still getting along and feel like you want to defer getting an LVAD, it's not necessarily a bad decision. And what you see here is that for those patients who choose medical therapy, part of the reason they chose medical therapy, this is your visual analog score of how you feel. Even though they had really bad heart failure, they actually felt okay. And so after a year, they still felt okay, and about a third of them went on to LVAD. The people who chose to get an LVAD early, well, part of the reason they chose early is because they felt pretty bad, and then after they got an LVAD, they felt better, but they didn't feel better than the people who already felt reasonable, even though they had bad heart failure. So I think that gets into, well, should you get an LVAD kind of a little bit earlier or wait until you're really decompensated? Well, the only way you can know that based on Roadmap data is really, how do patients feel? And the only way to know that is to really talk to them and ask them how it's going. So I think Roadmap only emphasizes the importance of patient input into these decisions. The other thing about the most recent Momentum HeartMate 3 trial, everybody says it's, this is a really important study because it's the first study with the HeartMate 3 where they did not distinguish whether you were getting a bridge to transplant LVAD or a destination therapy LVAD. And to some extent, whether somebody gets an LVAD, they get the same device with the same surgery with the same post-op care if they're bridge to transplant or destination therapy. But from the patient's perspective, if I'm getting an LVAD because I'm waiting for transplant, I just can't wait any longer, but I know within maybe a year from now, especially if I'm blood type A and I'm pretty small, that I'm going to go on to transplant. Well, getting an LVAD and living with that LVAD is actually a very different, I think, psychological construct than, okay, you're 75, you can either, and you have a lot of comorbidities, you can either go to hospice or you can get this thing and live with it for the rest of your life, regardless of whether you like it or not. To me, that's a very different question from the patient perspective. So I think when you think about talking about LVADs with patients and what's going on from the medical perspective versus the patient perspective, I think the indication for therapy is different and important. This is particularly important because the reason people are DT eligible is because of the fact that they're not transplant eligible, and the reason people are not transplant eligible is advanced age, comorbidities, psychosocial stuff, all of which is really important after they get their LVAD, right? They're going to struggle a little more, or if they have psychosocial problems, you're really putting a lot on these patients when you move forward. So, and then the last thing about DT LVAD, or just LVAD therapy in general, is that this is a therapy that has an incredibly high amount of caregiver role. So we don't implant patients. If we have a patient who's a perfect candidate, who medically is good and we think they can take care of their device, if they cannot identify a caregiver for 3 months that'll help them 24/7, 3 months after they get the implant, then that is an absolute contraindication to getting LVAD therapy. And the guidelines support the importance of caregiver role. So we're essentially saying to somebody, we'd like to give you an LVAD, and you can only do it if you identify a caregiver. And so it creates a very interesting dynamic around what the caregiver involvement is in these patients. So we, actually, Colleen McElvennon and a couple other people in our group, Colleen called 8 successive people in our program who were caregivers for patients who died. And this is, was published this year in JAMA Internal Medicine, and it is the smallest N I can think of an article in JAMA IM or a similar journal, because basically we care about this stuff. We try and do a good job around how do we take care of patients. Everybody sees palliative care, and we called these 8 bereaved caregivers and asked them, what was your experience when your loved one died with their LVAD? And literally all 8 stories are pretty horrific stories. I mean, they're describing like not knowing when to turn it off when their family member is dead. They describe going to hospice and the hospice doesn't know what to do with the device. They describe calling EMS and EMS is completely confused. I mean, these are really harrowing stories, and it just shows that as these technologies come online, they really affect a lot of people, even beyond the patient. So let's go to Act 3, which is that I think there are a lot of gaps out there in how we approach decision making for these patients. So our kind of go-to is informed consent, right? If somebody's going to go for an operation, particularly something like an LVAD, then we sit down with them and we have an informed, we have a discussion and have them sign informed consent. And actually, I will give credit to the ISHLT who puts out the guidelines around MCS and LVADs. When they published their first formal guideline in the Journal of Heart and Lung Transplant in 2013, they had this appendix number 1, which is the suggested informed consent document for an evaluation for LVAD. And I give a lot of credit for trying to include an informed consent document that's formalized that people could use. I will tell you that it's a start and not the answer, because this is a 7-page document. This is actually what it looks like. It has no pictures, no figures, no tables really. It is written at the 14.6th grade level, and it has a number of typos and spelling errors. So, this is what's in the literature right now in terms of what our standard of care is for informing patients about whether they should go down the pathway of getting one of these devices. So we have, I think, a long ways to go. The other is that informed consent is necessary but insufficient. It's the basic kind of foundation of the ethical principles around patient autonomy, but it is not the gold standard for an informed patient making a good decision. So the other is that I think because we haven't done a great job as a medical community informing patients, we've left it to industry to do that. And I have to tell you, I've had great interactions working with Thoratec and Heartware and some of the VAD companies. I actually think they deliver great devices. They work very hard to make those devices good. And I actually think in terms of bias compared to some other industry, they're actually not as bad. But I also don't think that we should leave it up to industry, who has a very strong conflict, to be the people to inform our patients about decision-making around these devices. So if you go online and you look, this is the kind of stuff they have. They always have these patients who do tremendously well. They got an LVAD. Their life is amazing. This is some guy who lives like literally in northern Minnesota, and he drives around in his four-wheelers, and he lives by himself, and he's 85 years old, and that's not what I've typically seen. This is actually a video and this video is entitled Shared Decision Making for LVADs, and this is produced by the company. So that's, that's what we were at our site. We were giving out, as of 4 years ago, to all of our patients, 25-minute video made by the company that says, basically, person after person after person saying, either you want to live or you want to give up. And when I woke up from surgery, I was so full of life. I knew I'd made the right decision. And there's barely a mention of bleeding, stroke, And so I really felt pretty motivated that was not the way that we should be talking to our patients about this kind of therapy. So I had a medical student who came to me and said he wanted to do a project. And this is one of the fun things about working at an academic medical center and working with students is one of the guys I worked with said, well, let's have them go to the library and just search for all the information that's out there about LVADs and then contact all the programs, including we contacted Emory. And we said, well, what's out there? So we found this is now about 2 years old, we found about 160 kind of educational pieces of information that were more than 10 lines available, and we got pamphlets that were made by institutions, and then we basically created a couple of very basic criteria to say that this is at least an educational material, and narrowed it down to 77. And what's kind of amazing is that 97% of these talked about the benefits of LVADs, but only 53% mentioned any risk, and only one of them talked about hospice or palliative care as an alternative. So pretty impressive, actually, in terms of what's out there. I think one of the things I've really learned over the last 5 or 6 years is how people make decisions. And so, I come from the Mountain West, and so Albuquerque is actually one of our referral areas. And so, this is how we learn about our patients, is by going to the medical literature. So this is from Breaking Bad in the very first season. So, I've been that doctor many, many times, right? Which is, I need to make sure my patient understands. They need to understand what their diagnosis is, what it means, what their treatment options are, and then we need to have a rational discussion moving forward about what this patient wants to do. And I think the biggest thing I've learned is that that's actually not how people make decisions. The first is that there's the whole grieving process, right? People start out with denial, then anger, right? You tell somebody they're dying of heart failure, they don't move right into acceptance and rational thought process. First thing they do is they barely hear anything you said, and then they're mad at me because I told them that. And I know that deep down, but what do? I just plow forward and just keep saying, well, if I beat them into submission, they'll eventually figure out that this is a bad diagnosis and they need to deal with it and do better. And I have to say that the research I've done has complemented the clinical work I've done, because I think I'm much more sensitive now to the way people react to that kind of information. The other thing I've done is I've spent a lot more time, I never took a psychology course the entire time I was in college, and I wish I had. I was spending a lot more time thinking about behavioral economics and kind of the way people think about things. And so this is Dan Kahneman, who won the Nobel Prize for prospect theory, and how people make decisions in various ways. And he talks about System 1 and System 2 a lot, which really breaks down the way that people make a lot of their decisions kind of automatically through default decisions, versus kind of the rational, more typical way that we think patients should make decisions, and that we operate when we're kind of going through our day, I think, with a lot of difficult choices. And so part of the way that we got into this is, again, Colleen McElvennon took 22 of our DT LVAD patients in a row and did semi-structured interviews, actually with people who are being evaluated. And a few things that we found from this. The first is that we thought we were going to really have a hard time finding patients who declined LVAD. We're like, everybody who's dying, really, at the end of the day, they say they're confused, but they really do want an LVAD. And now that we've been doing this work for over 5 years, what we found is when you systematically look at people referred to your institution for DT LVAD, I think we're finding at multiple places now, about 25% of people actually say they don't want to do it. The problem is you don't really remember those cases because they filter out of the system very, very quickly. So if you're running an LVAD program, the people you're dealing with are the people who are invested in it and want to move forward and keep going. And the people who filter out, you kind of don't remember as well. So that's one thing, is there are lots of people out there who are declining DT LVAD. And I think that it's helpful to kind of know that not everybody chooses this therapy. The other thing we found is that these people really do kind of divide largely between those who really do engage System 2 and are very reflective and utilitarian and think about a lot and kind of weigh risks and benefits, versus people who are automatic. And actually, at the end of the day, most people are actually very automatic and just say, well, there's no choice, right? I don't want to die, and you're telling me the best option is to get an LVAD if I want to live. And so, there's this gut reaction to survival. So a reflective person would say, well, I don't know if the pump would keep me alive, and even if it does, I'm not sure it would be worth living. And somebody else would say, well, did you weigh the pros and cons? And they say, no, I didn't even think about it twice. When they told me I couldn't have a transplant, this was the only option I had, the only option. It's not even a decision. That or push up daisies, so I automatically took this. So that's kind of the framework that I think we're dealing with more often. The other is, I think we don't recognize that kind of the way people think about heart failure and difficult diagnoses. So this is some work I did a long time ago at Duke, but we actually took 150 patients from the Duke Advanced Heart Failure Clinic. All these patients had chronic heart failure that was not felt to be curable. And we asked them just a questionnaire, and one of the simple questions on there was like, well, what do you think will be the eventual outcome of your heart failure? And 36% of people said it might shorten their life. 45% said that they would have a normal life expectancy. 9% thought they'd be cured. So this is an advanced heart failure clinic. This is not like, just people randomly pulled out of primary care. And I have to say, I thought the clinicians at Duke were excellent, and some of the nurse practitioners there were very sensitive to issues around palliative care. So, and this is my experience, that what people are telling you is partially misunderstanding, but also partially hope, right? If you ask somebody whether they're going to do well with their heart failure, they may know that it's a concerning diagnosis, but they want to beat the odds. And so they kind of answer these questions in that way. And our job is not to remove all hope. It's to help kind of at least help people, hope for the best, but plan for the worst. So again, some of the better medical literature I've read, Tuesdays with Emory, he says everybody knows they're going to die, but nobody believes it. If we did, we would do things differently, which I think is saying the same thing I just said. And so this is, I think, where the problem is that where do people want to die? Well, at home, rarely in the hospital, and not in a nursing home. But because of a variety of factors, 50% of people in this country die in the hospital and 25% die in nursing homes. And we spend a lot of money at the end of life, and I think we're going to increasingly have that conversation in the coming years. So I think this is going to increasingly become part of our dialogue at the national level and in the patient's rooms. So let me finish up in the last portion of this talking about the work that we've been doing to try and improve the landscape I just laid out. So Act 4 is what can we do? And when we started doing some of this work about 5 or 6 years ago, I had an impression of what we were going to do. And I think this describes it, which is limitations. Until you spread your wings, you'll have no idea how far you can walk. And, I thought we were going to do something, and it was, as you all know, it was much more difficult and much more challenging than I thought. But at the end of the day, it's kind of amazing, I think, how far the group I work with has come, and other people around the country doing this kind of work. So the first thing is, I love this quote from Lynn Stevenson on that she kind of, I think, paraphrased from elsewhere, but that we included in that scientific statement from the AHA, which is, difficult discussions now will simplify difficult decisions in the future. So I do think we need to be more proactive. Now, it's hard to discuss every option going forward. I think, the further upstream you get, the more hypothetical you get, and those conversations can get very, very messy. So, the answer isn't to discuss everything ahead of time, but I think it's to do it in a rational way that helps prepare people for those difficult discussions later. Because it's so difficult, I have increasingly felt that developing formal decision aids that support the conversations that I've been advocating for is really helpful. So patient decision aids are kind of designed formally to transfer knowledge in a way that makes the most sense, both in terms of the information that you provide and in the way that it's provided. Then they actually go further than just being educational. They actually solicit patient preferences, so that there's an active process of trying to understand what's important to the patient, and then they encourage a conversation. They don't replace the conversation. They hopefully elevate the conversation to a better place. And I think one of the ways to think about this is a meeting between two experts. I know a lot more about these devices and what they look like and advanced heart failure than most patients do. But most patients know more about what they want than I do. And I have to have a conversation to understand what's important to them and what their goals are, so that I can take that medical context and apply it to that. One of the things people think is that if we're doing shared decision making, I can't make a recommendation. Absolutely false. if I do a good job with a patient decision aid and have a great conversation at the end of it, I ought to feel very good about making a recommendation to somebody, because now I have spent the time to understand what I think that patient wants. Then I can make a patient-centered recommendation to that patient based on what I know about not only the medical issues, but what they know. The other is that one of the reasons I think we've gotten a lot of traction in our group is that a lot of decision aids have been very cognitive. And getting back to the Dan Kahneman stuff, we've actually tried to design decision aids that I think get a lot more into emotion, uncertainty, engage caregivers, and think about the cognitive biases that go into this. And this is the area I think that we're kind of pushing the envelope on a little bit, but I don't think anybody really knows how to do it. I'll tell you, one of the ways is to be very careful about including patient testimonials in a way that I think uses people's cognitive biases in the best way possible. So this is the decision aid that we've come up with. It actually starts out as a paper version. You can either hand out or download online as kind of like a PDF file. It actually starts off talking about emotion and the feelings around having advanced heart failure and thinking about getting major surgery to get a device. Then it actually talks about the fact that people are in a tough spot. I mean, it's not great to have to be considering a left ventricular assist device. And then only after kind of talking about the emotion and the difficulties, only then does it start to get into the information about what an LVAD is and what does it do. The other thing that's really important about decision aids is a lot of educational materials tell you just about the thing. But what a decision aid does is it talks about the options. And so critical to any decision aid is that you try and create what are the main options that a patient may be considering. You try and allow people to compare those options side by side, ideally, with the data that's most important to them to make that kind of decision. And so we try to do that here. Now, life with and without an LVAD is really the options that people are considering. And we can talk about what survival statistics look like, recognize that each person is individual. You don't necessarily know because there's uncertainty. But where we really had challenges is around summary of complications. So I know what your life might look like if you get an LVAD, but what are the complications of going to hospice, right? Those are a little harder to put down in graphic form because, well, you may not have a stroke and you may not have bleeding, you may not have a lot of hospitalizations, in part because you went home, and many of those patients died. And so how to express that in a way that is most helpful to people who are fearing death is, I think, challenging, and this is where we got to at this point in time. The other is people are really, really concerned about the burdens. So, people say, we hear folks say, oh, well, patients are really concerned about quality of life. And I think it's a little more complicated than that. For most patients, the most important thing is they don't want to die. And if that's important, well, then this decision gets pretty easy. However, people want to know what they're getting into. So even though they're probably going to go down the LVAD pathway, they do need to spend some time thinking about what the burdens are going to be so that they can process that. And so one of the most popular pages on our decision aid is actually, what are the burdens? How is this going to change my life? Because they know they don't want to die, they know they want to move forward, but they want to start preparing for what that's like. And so this we ended up getting the best feedback on. And then talk about what the alternative is. And this we also changed our thinking a little bit because it's not LVAD versus palliative care. It's LVAD versus no LVAD, but at the end of the day, most people ultimately end up with palliative care and potentially hospice, even if they do get an LVAD. And so talking about palliative care not as the alternative, but actually more as a support and a treatment option for everybody, I think it was something that evolved for us. And then the inclusion of family and how important that is, and how that actually, for many patients in their 70s, they don't want to be a burden on their family. And so understanding the role of the caregiver and what that can be, and how there are benefits and burdens to caregivers. Many caregivers are very happy to take care of their loved ones with an LVAD, but actually going through that process is very helpful. And then this issue of values clarification about trying to create a spectrum of, well, based on all the values that you have, which decision seems to make the most sense with that. That, like I said, one of the things that's come out to me is how important patient testimonials are. And, industry knows this, right? what do you get if you get an advertisement, right? Like if you want to buy shoes, they don't show you a lot about the shoes. They show you some incredible athlete that you want to be like. And we very much relate to people's stories. And so, if you go to industry sites, they don't tell you a whole lot necessarily about what the device does. They show you somebody who's doing really well with the device, because that's extremely powerful. If you're in the hospital, I don't know, for your program, Dave, do you have like people come in and meet with your patients? And that's very common. But the problem with patient testimonials is people want them and they're very valuable, but they're biased, right? It's an N of 1. So if I only meet one person out with an LVAD and they do great, well then it seems like a great option. But if we marched them down to the ICU and showed them the patient who just had a hemorrhagic bleed and is on a vent with an LVAD that had an infection in it, that would be also very influencing, but lead to a very different decision. And so one of the things I really like about decision tools is that you can incorporate in a much more controlled way patient testimonials. So we've gone to a video decision aid that's 26 minutes. It includes video clips of patients, but it allowed us, rather than trying to find whoever wanted to come in and meet our patient for the day, who mostly, is a cheerleader who loves LVADs, who wants to come in and help the program, but has a very single biased kind of story, we're able to take a video and combine a whole bunch of patient testimonials that give you a better perspective of what are the possible outcomes with LVAD. And to me, that's incredibly powerful. But we included people who had complications. We included caregivers who have struggled. And then the hardest thing to include is people who turn down the device. And it's hard to get somebody who turned down an LVAD to come in and meet your patient, because a lot of them aren't around anymore. So being able to have a video decision aid and include all those different perspectives together, to me, is very powerful. And I think that's actually one of the things that is most valuable about the work that we've put together. So we actually published kind of the decision aid that we developed, and if you are thinking about making a decision aid, there are actually international patient decision aid standards out there. This is a very well described literature around the science of doing this, and so you conduct a needs assessment that says what's out there, what do people need, what are their preferences, and then you kind of develop a beta version of your decision aids and then kind of go through this iterative testing process. And so we ended up with an 8-page paper and a 26-minute video, and people really do enjoy watching this video, I think. And then now we're in the process of dissemination. And these are available for use for anybody around the world that wants to use the decision aids. So the fifth act, and let me just finish, is about dissemination and implementation. And it's interesting, PCORI was created under the ACA to help kind of make medicine that's more patient-centered. And initially, in the first 2 years, 60% of the money that they spent was actually in developing decision aids. And after 2 years, they said, we have developed a whole bunch of decision aids and nobody is using them. And so they actually now, if you were to apply for a PCORI grant, you have to answer 4 questions, which are like, are you a citizen, and something, and the 4th question is, are you developing a decision aid? And if you answer yes to, I'm developing a decision aid, it says, no thank you, we are not accepting your application. And the reason for that is that the problem isn't developing decision aids, the problem is getting people to use them in practice. And so we actually wrote an award after we kind of cobbled the money together to develop the decision aid to actually test this. And so this is the work that we're just finishing now. We have a 3-year randomized controlled trial, but it's actually a stepped wedge center randomized study where we rolled out our site and then we rolled out 5 other sites over time, where everybody starts in their usual care, and then gradually we transitioned all these programs over to replacing the industry materials with, or at least the decision-making industry materials with the decision aids that we had, as well as some kind of education and other parts to this. And we are over 2 years into this now, and we're just finishing actually enrollment. This actually has been pretty successful. We have enrolled 244 patients prospectively to ask them about the entire process of what are they thinking, how is this going, what information were they getting, what was most useful, but also about the emotion, depression, anxiety around it. And so we're up to about 250 patients prospectively enrolled and 170 caregivers. So this will be one of the largest actually LVAD studies that was prospectively done, and it will be the largest caregiver, I think, formal caregiver study that's ever done. The other is that we've been looking at kind of organic dissemination and natural implementation, and Anne here with Rob Cole actually sent us an email recently, and we've gotten a lot of these where they say, hey, I saw your decision aid, and we were wondering if we could use it. And we were like, yeah, that's great. The only places we told them that they couldn't use is like a social worker from Duke who's in our study emailed us and said, hey, can we use your decision aid? And we said, actually, no, you're in our study and you're not slated to roll out until November of 2016. So we've encouraged people to use this. And what we've found is that 35 people from 31 different organizations have contacted our research team just kind of haphazardly and said, can we use this? It's been from the US, but also Canada and France. And we now have 8 LVAD programs currently using these decision aids, including the entire country of France, which is kind of cool. And people in Quebec actually translated our decision aid into French, and then we recently translated them into Spanish. There are additional programs who are thinking about using these, and so it's kind of nice to see that when there's an area of need and you provide something, I think that makes sense, people do actually use these. So I think there are many lessons to be learned from that, and this is kind of a side project that we've been collecting data on. So those are the formal slides I have. I do want to thank some of the people I work with. I think, Neil, you know Dan Matlock, who is a geriatrician who's been very interested in decision making and has taught me an incredible amount about this work. And then we have some other collaborators and research assistants who do an incredible job working with us and are very passionate about the work. And obviously the patients and caregivers are very inspiring, as are a lot of the clinicians that we work with. So actually, I think you all were considering using the decision aid materials. They are available online and just can be downloaded by anybody on a phone or a computer. So I'll open it up to questions. I think we have a few minutes. But again, thanks for letting me come and share the work we've been doing.
So Larry, thanks very much. That was a fabulous talk. I guess maybe I'll open up with one question and see if some others people have some others. One thing I think is really, really interesting about the decision space, and obviously there's been, I think, an increasing awareness of this, is how do you decide when something works? Right, so how did you guys think through the process of kind of the outcomes that you thought were meaningful in doing a trial of a decision support tool in this space?
Yeah, so I guess I'd answer that in 2 phases. The first is when you're developing a decision aid, there's kind of this iterative process to get a sense for whether you're doing the right thing. And there's no such thing as a perfect decision aid. I think what you do is you keep tinkering with, you kind of gather a lot of information, you hopefully have some experience in the field, both medically as well as in terms of developing decision aids, and then you kind of develop a version, and then you basically keep getting feedback on it. And we actually had 20 separate versions of our paper decision aid and 4 versions of our video decision aid, where we would develop it, we would then present it to a group like you or a group of patients. We had an IRB process for this. And you keep tinkering with it and trying to make it better and better and talking to people and incorporating ideas. And then at some point, you basically saturate and say, you know what, it doesn't seem like it's getting better. The other thing is that there's always bias, right? It's like history. Like, you know, there's no perfect way to tell it. And so, you know, I think you get a sense for when you're pretty balanced in your presentation, not when everybody says, oh yeah, that's really balanced. When we felt like we'd hit balances, we would go to the CT surgeons and they would say, oh my God, that is so negative against LVADs. And then we would go present to the preventive cardiology group and they'd be like, oh my God, that is so pro LVADs. And then we would say, you know, I think we've hit the sweet spot in terms of bias. So that's kind of the iterative process, and that's actually well laid out by IPDAS and others. In terms of implementation, about whether the tool that you're using is useful, we're actually using the implementation framework called RE-AIM. And so RE-AIM actually defines a couple of things. The first 2 are the reach. Does it get to the patients? And then effectiveness, which is do you improve patients' knowledge and do their decisions Are the decisions that people are making concordant with their values? So those are kind of the patient-centered stuff. Do people get it and use it in a way that makes actually their decisions better? And then we also look at the AIM piece, which is adoption. Are people willing to take it up? The implementation, which is, are they true to the fidelity of it? How are people using it? And then the most important is maintenance, which is our study ends in terms of our formal piece of it on January 31st, 2017. So the key is now we've got all these sites using it as part of the study. When the study ends and we stop paying people to use it and telling them to use it, do they keep using it afterwards? And so maintenance is I think one of the real key pieces to this is do people keep using it because they find it helpful? So go ahead.
One perspective you hear about educating patients is that we don't all read at the same level.
Yeah,
And secondly, we don't all learn by the same modality.
that's right.
How have you addressed these?
So great question, and people involved in decision-making or decision science obviously spend a lot of time about addressing the issues that you talked about, which are literacy, numeracy. So we're actually collecting information as part of our study around literacy and numeracy measures, first off. The second is that I told you that the ISHLT informed consent is at the 14.6 grade level. The tool we developed is 7.6. So it's much lower, and we spent a lot of time working on making that information as easy as possible. The other is that we developed both paper format and video format, not just for practical reasons, but because people do learn differently, and I think they actually kind of go together. The other is some people talk about tailoring decision aids, and I think there's a lot of interest in doing that. So far, my gut on this is that you create a lot more complexity in tailoring, and you actually don't necessarily improve the quality of the information that much, but that's an area of controversy. So those are a couple of answers to it, but you clearly have to be very concerned about how do you deliver that information to people in a way that is useful to them. The last thing is this concept of gisting, which is that the goal is not to give people every single piece of information that's ever been out there about LVADs. The goal is to give them the information that they need so they can make a decision. And so a lot of what you do when you go through this process of iterative development is to figure out what is the information people need and how do you present it in a way that makes sense. Like to some extent, whether people have a stroke rate of 7% or 11% is less important than getting across the fact that about 1 out of 10 people have a stroke. To me, that's an example of gisting. The other is stroke is very important to people, so that's got to be a piece of information, whereas some other events may not be as relevant to them. So those are all part of the answer. Go ahead.
Thank you very much. Let me ask you a question about why you think the risk models aren't as accurate as they ought to be. Do you think that's a pathophysiologic gap in our understanding? Do you think it's just the heterogeneity of disease process? Do you think it's just that we haven't bridged the gap in terms of, whether it's an electrical issue or a mechanical issue? Or do you think it's that we haven't deployed techniques like machine learning or other tools to try to refine those?
Yeah, so great question. I love to talk about risk models because I actually started my research career kind of building risk models and saying, gosh, if we only knew who was going to die, then we would be much better at deploying these very expensive therapies. And so I do think that there are ways to improve risk models. So machine learning is an example. I think one of the things that's missing is kind of all the socioeconomic stuff. We know that for some therapies, the ability for patients to engage the therapy and adhere to recommendations is really important, and those kinds of things aren't usually very well captured in risk models. So I think first is we can do a better job with risk models in terms of making them. And there's some ground to be made there, and there are a ton of people doing that. I mean, there's another risk model every week in the literature about, heart failure and some kind of outcome. But increasingly, I've just gotten pretty negative about that because I think we spend all our time on that, and we don't spend very much time on what are the inherent limitations with risk models applied to individual decisions. I mean, the best way I can describe this is shit happens, right? Like, I'm feeling pretty good. My risk model says my chance of death in the next year is less than 1%, but I could walk across the street and get hit by a car. And, I think that's the way medicine plays out. And one of the great examples of that is with LVADs. So if you look at the risk model, and some things are more unpredictable than other things. So whether somebody has a groin bleed after a cath is actually a pretty predictable event. There are people who have groin bleeds and people who really don't have risk for that. Whether you die after you get an LVAD is extremely variable. Whether you have complications that lead to death have to do with lots of factors that haven't happened yet. So if you try and say this patient is going to do well with an LVAD or not do well with an LVAD, the C indices for those kind of models are like 0.64. And every time we try and make a better model, the C indices don't get any better. And the reason is because the variables that go into whether you die after you get an LVAD haven't happened prior to LVAD, to go into surgery for LVAD. It's just the things that cause you to die are usually unrelated to your pre-LVAD status.
What about predicting pre-LVAD? What about you have a patient with end-stage heart failure? What about predicting death and whether it's arrhythmic or pump failure death? Don't we, over the last 20 years, have enough pathophysiologic understanding of that process that we should be able to refine?
That's what I was saying, is there are literally this systematic review from a year ago. There have been 2 systematic reviews of heart failure survival models. So exactly the question you just asked. Over 100 models developed and published in the literature, many of them validated, and they're okay. I mean, they have C indices in the 70s. But they're not perfect. And the problem is when I have a patient in front of me and they're on inotropes and they're in the ICU, I have to tell them either, well, let's keep trying to wean you down or send you home, or you go to surgery, or you ought to go to hospice. And as it turns out, because of the way the hospice benefit is designed, they won't pay for your inotropes. So how comfortable do I feel telling that patient, you've got to go to the OR now, because if you don't go to the OR, you're going to die? And that guy, Don Brees, I showed you, so I thought he was dead, and I pushed him very hard to get an LVAD, and he wrote me a letter saying, I'm a person who believes in having patient choice. He actually wrote me a letter and said, I feel like you're not hearing me, and I really don't want to do it. And what's crazy is a year and a half later, he's still alive. Anybody who does this can tell you those stories.
Could I ask you a question along those lines?
Yeah.
It seems that the decision aids are still very focused on the therapy. Mm-hmm. And what thought did y'all have in developing these about getting people to focus on their individual life story, and where in this, you're 72, this might get you to 75, it might get you to 76. What have you done to think about what you've accomplished in your life? What do you need to do? That's part of it. The other part of it, and I've read all of your papers, and just there's so much to learn in reading them, is that, patients with the very worst heart failure, they're drowning. They cannot breathe. And so many, as you've noticed in your papers, after they've had the device and had a major morbidity and complication, that in general the regret scores tend to be pretty low, that they are still glad that they did that. And so how do you sort of fit all that in?
Yeah, I guess I'm going to answer it a little bit tangentially, which is that a lot of the work that we've been doing now in our group is actually around palliative care and hospice. It's still to some degree a therapy-based decision aid or decision tool, but it is a little more about the philosophy of how you want to live the rest of your life. So as it turns out, we actually are just getting ready to, we're putting the finishing touches on a paper that's a needs assessment for patient decision support tools for hospice. There is none out there. We can only find 7 that talk about hospice in a decision aid, and they're all as an alternative to some other therapy. So one of the 7 is actually the decision aid I just showed you. So one is, I absolutely agree with you, there's a huge need. I think it gets very philosophical about fear of death and how do people want to live their life and how do you do that, and that's partially our job, but it's partially society's job, and how do we think about end of life in this country in a way where it's not failure, because it's not always failure. So we're working on that. I don't know the answer. I would love to engage you and Neil and others a little more around that. But we're also interested in that because I agree with you. We're not there.
Thanks, Larry. That was fabulous. And obviously, Larry's around for the rest of the day, so many of you will have a chance to talk with him further. Thanks again.
The preceding program is copyrighted by Emory University.